Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SECA, where we partner with healthcare professionals and clinicians to offer body composition solutions. I'm so excited to be joined by Colleen Sloan today. She is dual-credentialed and works as a physician assistant and registered dietitian. And she's in a pediatric outpatient setting in Florida. And she has a really great podcast called Exam Room Nutrition, which I've been a guest on. And she's just been a really great force in this field. So I'm really excited to have you here to kind of continue our conversations.
Nina, thanks so much for having me on your podcast. It's been such a joy just to connect over these years.
I love it. So the thing I really wanted to kind of dig in with you today, you've been in this really unique space, kind of in the primary care setting, working in nutrition. I love the way sort of you're asking questions on social media and engaging, the other healthcare providers in that audience about nutrition, about obesity care. So I thought we could dive in a little bit to some of that and really think about how even body composition is being received by and talked about by the primary care setting. And we're seeing so much more interest in it as people are, prescribing medications and understand the responsibility of an effective medication that can change your weight. So I thought that could be a fun topic for us today.
Absolutely. I think we all need to learn more about body composition and how we can incorporate it into the primary care clinics, because that's where a lot of our patients are getting filtered in through.
Yeah, there's so many obesity care specialists, but so not enough to really meet the demand. And so that's, again, what I love that you're doing is giving practical skills to the providers who are doing this day in and day out. So one of the things I really wanted to hear, your perspective on is why you think the primary care field is still so heavily reliant on BMI and weight. And so even though we know there's so many limitations, I feel like we hear every day people saying, beyond BMI, and we're talking about that. And yet they're still not necessarily across the board putting body composition in their clinics or their workflows.
Yeah, BMI, we all have heard, is not, there's tons of limitations with it. It's not ideal for assessing true weight loss and success on a patient's weight journey. But if we've had it for so long, it's fast, it's cheap. It's easy to calculate. You don't need any special equipment or special training on how to do it. And like we've talked about on my podcast, it takes a while for these clinical practice guidelines and insurance to kind of jump on the bandwagon with what we're seeing in research and in clinical practice, kind of getting current and up to date with the guidelines and with the recommendations. So I think that's a big reason why it's not utilized. Body composition isn't utilized as much because we are just so comfortable. We've been using BMI for years. Patients are sort of also used to hearing about their BMI or using that to track their weight or their success or their journey through weight loss is kind of a measure of success, and kind of hearing like, oh, your BMI is 20, your BMI is 35. It puts you in this range. We're kind of also used to that language that I find that when there's something newer, like body composition, we all just might be a little bit timid with how to explain that, because it does take a little bit more training to have that conversation with a patient. So I think that's a bigger barrier as well. Plus, a lot of primary care offices are owned by corporations. And so even if the clinician themselves wants to use body composition in practice, they might need to get the buy-in from the owners of the corporation, from the shareholders of that corporation. So it might take a little bit of education on the clinician's part to get that corporation to agree and actually implement that in practice.
And that's a good point. Yeah, I think, we do have a lot of conversations about people who want to do it, and then they kind of get to that, maybe the price point. I think, one of the things you talk about a lot in your work is about time, and how do we make this not be seen as an extra, but as something that's essential?
I talk about time all the time because I've polled my audience multiple times just to really find out, like, what is your barrier when talking about nutrition? A lot of it is they don't feel confident. They maybe don't have the language or the words because they do want to be compassionate. They don't want to stigmatize their patient, but having nutrition and weight conversations can sometimes feel awkward. And so they don't know what to say and how to say it. And then the other big one, and I would say this is the majority of my audience, does say there just isn't enough time to talk about nutrition or weight. And I actually agree in some way. Now, I do think that it's possible. There needs to be a strategy, and you have to be intentional with, how you how you organize and you flow the conversation when you're with a patient for 10 or 15 minutes. And that's the reality of primary care now is we have maybe 10, maybe 15 minutes for an annual checkup. And so I do feel bad for medical providers because we are sitting in this tension of our templates, our schedules are set by, again, the corporation or the practice that we work for. So we really don't have any say for how many patients we see, how often, the schedule is set. But we're also have the responsibility to work through everything that we need to work through in an annual. That's referrals, that's labs, that's the patient's chief complaint. What if, they're there for their annual, but they also have a rash, or maybe they're also sick, or, they're constipated. There are other things
Yeah.
that a human is dealing with besides just their annual checkup, and then now throw in nutrition. And if they want to lose weight, if they ask you like, hey, I would like to lose 30 pounds, like, how do I do this? So finding ways to have those conversations in that allotted time frame is a huge challenge and is very, very stressful. Now, I will play devil's advocate for this because my audience is kind of a mix of clinicians and dietitians. And I will hear dietitians all the time shouting, well, just refer to a dietitian, just refer to a dietitian. And I 100% agree. I think this should across the board, we should be referring our patients to a dietitian for a plethora of reasons, not just for weight management or for diabetes education, but for so many reasons, we need to bring dietitians on the healthcare team to help facilitate that conversation. Yes. However, I also sit in the provider seat. And when a patient is sitting in front of you, asking you a nutrition question, honestly, they're not going to be happy with you if you just say, oh, I'm going to just refer you to a dietitian. Maybe you can get an appointment in 2 to 6 weeks, or your insurance doesn't cover it and you've got to come out of pocket. You feel the need to answer their questions. And so that's where I think this education component with my podcast can really help to give that evidence-based, scientifically backed, compassionate answer to the patient that's sitting in front of you, to at least give them something to start with, some answer to their question to at least get the ball rolling. And then you can pass the baton to the dietitian to maybe help you explain their body composition or to help them along their journey for weight management. Because it's true, clinicians can't do it all. But I do feel like there are strategies and ways to implement body composition and those weight conversations during those visits.
Yeah, that push and pull, I think, is really it's important to address and not just say refer everyone because, really coverage and access and time and where the visits are happening, all of that matters. So I know you've been kind of outspoken on, do we need to educate all the providers in nutrition? Maybe not. Do we need to strengthen referral networks? Absolutely. So I always appreciate a good nuanced non-black and white, all or nothing kind of an answer in that too.
I've been very passionate about this RFK kind of proposal because it kind of blew up on social media. And there was a lot of buzz and a lot of opinions about whether medical schools need to provide more nutrition education. And I had a lot of thoughts about this, although I didn't go to medical school. The PA program I went through was attached to a medical school. So we were kind of going along with the medical students. And I have a lot of medical doctor friends, and we talk about their experiences. And to make a blatant statement that doctors don't get any nutrition education is actually false. The majority of them do get some. I would argue that it's not enough. However, my point was we don't necessarily need to make them experts in nutrition because we have registered dietitians who are the experts. Plus, again, this goes back to even a doctor is an expert in diet in nutrition. For example, myself, I'm a PA, I'm also a dietitian, so I would consider myself pretty well versed in all things nutrition. When I have my PA hat on, I don't have the time to go through a very long nutrition counseling session. So,
Mm,
despite all of the training that I've had, if I'm sitting with a parent and I'm doing a 4-year-old checkup, all the things I have to do through that checkup, and then they say, oh, she's really selective and she drinks 40 ounces of milk and she's constipated. I do have the answers for that and I can help with some of those and maybe give a few quick tips that can help. But to unpack the weight of selectivity or with adult medicine, weight loss, that takes far more time than maybe the 3 minutes I have left over at
mm.
the annual physical. And so that's where I think that team approach with giving them some solid information, explaining things to them today, maybe giving them one or two quick tips or things that they could start to implement, and either schedule a follow up. If you do feel confident in having those conversations, have them come back for a dedicated visit for that issue, or then utilize your team and pull in a registered dietitian to then walk them through and hold their hand to give them a better path to whatever hindrance or whatever complaint that they're coming in with.
That's big. The whole sort of operating at the top of your scope of practice part, I think that's important. Even though you can doesn't mean you should, right? And I think that idea of really understanding what a comprehensive care team is really does come, from the primary care, from that clinician who's sort of, "Hey, I'm your portal to all the other people that you might see, but they might only see you." And so if they don't come back, it's sort of that, give them enough to get them started. I love the language and the way you're phrasing that too. Get them started, get the ball rolling, and explain what would happen in future visits too. I think sometimes the referral process is so quick and just see a dietitian. That doesn't help. What are they going to do? We know how judgmental people are towards our profession, right? What do they think we're going to do? Well, why do I need to see them? I already, follow these people and I can just do what they say. And so all of the counseling, the motivational interviewing, all of the stuff that makes it hard to change our behavior, I think you can kind of lead them to understand that would be what you come back for too.
100% agree, especially with that behavior change piece. A lot of dietitians are so well versed in motivational interviewing because, as we know, weight loss is really, it's a struggle, and it's not just because of biology. It's not just because of a lack of willpower, what we've been told years and years ago. It is now they need that support. They need to understand, well, why am I eating when I'm stressed? What can I do? Why do I seem to eat when I'm lonely? Or why
Mm.
don't I feel hungry? Like why do I just feel like an empty vessel that just consume all of these foods? And that's something that you really need to, again, like, counsel a patient. You need to
Mhm.
have those back and forth conversations and multiple conversations, because a strategy that might work for patient A, who is an emotional eater, might not work for patient B, who has the same kind of emotional struggles. You do have to troubleshoot and navigate and give different suggestions and guidelines. And that's where I think just giving clinicians more education really misses the mark, because I don't feel like our patients don't know enough. Most of our patients are well educated. And now, in the world of AI and ChatGPT, you've got plenty of information out there and you can find anything that you need. But it is that, how do I navigate the struggles in my life that are specific to me? And that's where I think dietitians come in, and that team approach is the most beneficial for our patients. But yeah, it's that tension of, you want to give information. Your patient really does want some sort of guidance. And I think that's where clinicians have this sweet spot to give really helpful, motivational, informative tips and tricks that they could try. And then, yeah, explain, I'd love for you to meet a dietitian. Here's what they would do, because, they're not the food police. They're not just going to give you
Right.
a list of foods to eat, not to eat. Most of them probably won't just give you a meal plan, because we know that that's not enough these days, and most people don't really follow them anyways. And so, explaining what that might look like, what that visit would be, I think is also really, really helpful for them too.
I really love, kind of focusing in on sort of the difference between education and counseling. And that alone could be a whole, at least 15-minute visit just to explain again what people think this is about versus what it actually is. And in the field of nutrition in general, I think we struggle with this. Like, I think social media does a really medium job on information. Like you said, there's tons of information out there. I'll be really curious to see how, chat gpt and AI works to help connect information to the individual and personalize it over the next couple years. But yeah, I mean, this is literally like, I, as an RD, I did not have enough skills to help people with behavior change, and went back to school for a psychology degree to figure that out, recommend that pathway all the time. But it made me really good at helping people connect, some of the psychological behavioral stuff to the food and eating part of their world. But it's not easy. And I mean, the question that, or the comment that I thought I heard the most, was people saying, "Oh yeah, I know what to eat. I know how to do it. I just struggle to do it long term." Right. And so that's the piece, is it's very rare that dietitians are education only, advice only, information only. It's taking and assessing where the person is at, what they know. I mean, you don't have to start from scratch with everybody. I made that mistake a few times early in my career where I went in and thinking, okay, I'm going to just launch into my, spiel or my conversation, not very patient centered, just like, okay, we're going to do a heart healthy education on this one. Um, and not recognizing where the person was at. Very memorable story of a patient who was a dietitian. I didn't ask her know anything about what she knew or where she was at. So I wasted a whole bunch of words and time on all that beginning stuff. And if I figured out where she was at, she could have said, well, here's what I know and here's where I'm struggling and how can you help me get there? That's more rewarding for everybody. And it's much more likely they're going to result in change. So I love that piece of like, this is not, and just reminding people, it's not just about information and education. You probably know more than, definitely know more than I do about your own story. And so I think that's key. So in primary care, I'm glad to hear, that's happening.
Okay, your story about having a registered dietitian as a patient, I had a very similar thing happen as well. She was the parent and, she was like overwhelmed because her child is a very selective eater. And I mistakenly did not realize or ask or know like what she does as a profession. And after I wasted 5 minutes of going through like basic pediatric nutrition guidelines and portion sizes, she's like, yeah, I know that I'm a dietitian. And I just wanted to put my foot in my mouth because I just was really mad at myself because I wasted 5 minutes. And that brings us back to what I had talked about in the beginning, that although clinicians feel like they don't have time, and I agree 100%, I'm in a really high volume practice. And so I totally get what it feels like to be in a factory of medicine. I think we are wasting our time unintentionally. And I feel like there are places that you can reevaluate, where am I wasting my words and my time, where I probably, if I would have gathered some information first, can now really zoom in and provide information and support for their specific issue. And that's what I love, your question of like, how can I help you? Or I really love starting out with, if a patient asks a question, I like just bouncing it back and asking them a follow up question. Maybe the patient's like, my neighbor is on intermittent fasting and he lost, 97 pounds and he did it in 2 weeks. Like, I'm thinking about doing intermittent fasting. What do you think? And instead of, just maybe giving an education or informational
Mhm.
answer, I like bouncing it back and say, oh, okay, wow, that's really interesting that it worked for him. Tell me, what do you know about intermittent fasting? Right? Because now you're pulling out, like, do they even know what it is? Do they know what that strategy, that meal pattern looks like? Because if not, now you do have to start from the basics. Half the time, a lot of our patients are doing honestly more research on these diets than we are probably doing as a general practitioner. So asking them what they know is a fantastic place to start to not waste that precious time that we feel we're so limited on.
It also reminds me in some of the tenets of motivational interviewing, it's gathering that information neutrally. And that neutral piece is not launching into, well, here's my opinion on intermittent fasting, right? I mean, I think a real evidence based practitioner takes the best available evidence along with their experience, but finds out the patient's goals. So it might not be your favorite way to talk to someone about changing their eating habits, but if it's what they're asking you about, it's what they're going to do anyway. And you can share the evidence and give them, a little bit of your experience.
Yeah, it's the principle ask, offer, ask in motivational interviewing. And I know you and I are so aligned in how we discuss this with our patients. And first ask permission. You and I are so committed and compassionate about asking permission in so many things, not just about, hey, can we talk about your weight today? Or, hey, let's talk about your diet, but even asking permission to giving a suggestion. Sometimes patients, maybe they just are sharing information and they actually don't want your advice or your blessing on whatever diet that they're trying. They might just be telling you about it because that's what they think they're supposed to do. And I know a lot of clinicians kind of get stuck in this kind of tennis match with our patients where we just give some advice or a suggestion. Hey, you should drink more water. And then they ping pong the ball back to us and say, well, I don't like water. And then we just say, okay, well, then maybe you can eat more fruit during the day. And then they say, well, I don't like any fruit. And we're in this like back and forth tennis match, which is honestly exhausting. It's like a one-way ticket to
For
burnout,
both
to
of
like
you.
hating your job for everyone involved. Yeah. And so that strategy of ask, offer, ask really eliminates that tennis match between you and your patient. And so the kind of the surface level of it is the first ask is going to be asking permission. And you and I both love asking permission, especially when it comes to talking about sensitive things like a patient's weight or body size and their food choices. So, another way you can ask permission, though, is by asking if it's okay if you make a suggestion. It sounds like you've been really struggling with your weight. I'd love to give you some ideas that have worked with some of my other patients. Would you be open to that? So now you're asking the patient if they are open to hearing some of your suggestions. Then the offer is giving them a few different suggestions. Offer a menu of options. So, two or three things that maybe you've already talked about or that have truly worked for your patients, or, that maybe that could work for this patient, drinking more water or carrying a water bottle with you, taking a 10-minute walk after meals, or maybe just focusing on how you're feeling with your meal and being more mindful, chewing thoroughly, paying attention to your hunger cues. So offer a few ideas. The next and final ask is to then ask them, which of these sounds like something doable for you this week? And, they might say, oh, I'm not interested in changing my diet at all. I hate walking, but I think I could, maybe buy a water bottle and focus on water. So I love that strategy so much as a way to really connect with your patient, but then also allowing them to make the goal for themselves for that week, because then they're much more likely to stick to it and feel confident in making those changes and those steps because it's something that they own, that they kind of came up with and agreed with on their own.
I love that. I think I called it or read it as elicit, provide, elicit, right? Where, and then,
Yes. Yep.
that final one of how do you make sense of this? And really that check-in and rather, I think what we do naturally without skill building is just, well, I told them what to do. They came back, they didn't do it, and you're all frustrated and no change
Mhm.
happens. So I love that. I think that sort of, and, how do you make sense of this? What do you think of this? Or the way you said it is, what can you do this week? I think that really does inch towards some better change and definitely some better relationship.
Yeah, exactly. And it prevents us from labeling our patient as, quote, non-compliant.
I like that word. I could do a whole talk
No,
on that word.
me too.
Well, we won't, right? So, Colleen, this has been an awesome conversation already. I really appreciate sort of your perspective. I think you've got that really nice dual perspective of what's realistic in the clinic, the background of someone who is an expert, but I also really appreciate, what's feasible and kind of that provider experience part of the evidence-based practice approach is really important here. So kind of for me thinking, how do we approach the primary care sector a little bit more? How do I help move the needle for them on using outcomes other than weight? They're saying maybe a motivational interviewing approach, right? They're saying they don't want it. They're saying they want to use other things, but then they're stuck in this, but it costs too much and I don't have time. Like, how do I get to that next step with our primary care providers?
Well, I do think education is key, right? So, body composition analysis maybe is not so much new, but it's newer to in practice. Gyms have kind of been using it for a really
Right.
long time. And it may be new. So I think first by kind of explaining it, and I love how Sika has those printouts of exactly like what information is given to the clinician. So I think showing them like this is what you get and explaining why having this information, skeletal mass, fat mass, water weight, like all of those things, helping the clinician see like this will help you explain to your patient what's going on in their body if they're frustrated that maybe they've been dieting and working out and doing, quote, all the right things, but they've gained 3 pounds. But maybe if you put them on a scale, like a body composition scale, they've gained 3 pounds of muscle, right? Like that gives them such valuable information to then support their patient much further than maybe guessing, like, why did you gain 3 pounds? Like if it's just based on BMI or the scale weight, you don't really know what is that 3 pounds where is that 3 pounds coming from.
Yeah.
So I think giving that piece of information of like this is such valuable information to help your patient and to motivate your patient too. Like how awesome is that to see like, oh heck, it's been 3 pounds of muscle mass that I gained, and all of my efforts that I've been putting in the gym are actually getting me to where I want to go. So I think it's a really great piece of information to help the patient stay motivated and stick with it if they can see that all of their efforts are worth it and are getting them to their goal.
Yeah, helping them help the patient, and making their job a little bit easier. I think that's also a good frame.
Yeah. Yeah. And then I think also, you know, showing them the MAs can easily be trained on how to do this with the patient, giving the MA some language that's non-stigmatizing and to help, you know, them explain how to do this respectfully, but also that it really doesn't take that much more time than putting a patient on a regular scale, getting their height and weight, right? Like there's not that much more to it. So the time argument is kind of null because it's going to be replacing the time that was spent on a traditional scale.
Yeah, and then thinking too, how to engage the comprehensive care team, maybe the measurement gets done in the office that day, but maybe the explanation can be done, at a visit later that week with, dietitian or someone else on the team to go more in depth and connect it to their goals and all that. So, yeah, that's a great way to phrase it. Thank you.
Going off of what you had just said, I would love to see that. And I think as a clinician, even me, my shoulders just relaxed when you had said, we can collect the information. I can
Mm.
maybe give you a little bit of, what it showed. But then if we could have a partner that could follow up with the patient and spend the 10, 15 minutes explaining, okay, hey, we got your numbers. This is what it means. This is how you're doing. Like, this is what you can do moving forward. I think that support makes the clinician feel like they don't now also have to be a body composition expert as well
Right.
too. So finding that team approach of having an expert be able to explain this to the patient on a more deeper level could be a really helpful component of that for the primary care clinician.
Yeah, we've worked and partnered with In Health, a company that does coaching, and so that's been one way to do that. Where the doctor's office, they partner with someone who has that in their practice. They have the body comp scale. They do it then the coaches will do the. I've taught them my whole kind of framework of how to explain the results to the patient, and they've been able to do it that way. So that's another solution. So yeah, that actually gives me some whole new set of ideas to think through as well. So I appreciate that. Before I let you go, though, I want to make sure that we tell everybody about what you have coming up because I'm really excited to have been part of it. I think, we're in a really interesting time in this space where many more providers are craving and wanting to know how to support patients who are on, variety of obesity management medication. And so, tell us a little bit about what you've developed to help kind of fill that need.
Oh, thank you so much. I've created a course called the Obesity Medicine Nutrition course. And this course has been a passion project of mine for almost a year now. And I'm really, really excited to have finalized everything. And you were such a big contribution to this course because I really wanted to make a big focus body composition analysis because clinicians, we really only know how to measure and track weight and BMI as outcomes. And we have so much better useful tools to help our patients on their weight loss journey. So, one of the module that you did is all about going beyond BMI and utilizing body composition analysis in our practice and how to explain that to our patients. So, if you're listening to our conversation and you're like, well, how do I explain what I saw on a body comp scale? Nina's course, Nina's presentation, it goes in depth in that. And I learned so much from you. And so beyond that, though, this course is just a comprehensive training for any clinician, whether you're a PA, NP, or an MD, and whether you're in obesity medicine or primary care, and honestly, even endocrinology or cardiology,
Mm.
weight comes up in a variety of areas. But it's also for dietitians. So also, if you've been out of school for a while, you need to stay up to date with current guidelines and where nutrition and medicine is going. And so this course takes you from the beginning and understanding and explaining the weight loss dietary the dietary patterns that you can select for weight loss for patients. So, not just one diet is going to work for all the patients. And so helping you choose the right one for the patient in front of you. And then beyond nutrition, we do talk about obesity management medications and go in depth of how to choose the right one with that patient and how to manage side effects and then answering some common questions and barriers to those medications. And then beyond that, we take it a step further. Like we've talked about in this podcast, you do have to give your patient more than just education. Sometimes they don't just need the facts, they need help with the application of that information that you gave them. So we talk about some behavior change strategies, helping patients create identity based habits, and of course, how to incorporate motivational interviewing in your counseling with your patients. And so it's a really comprehensive course. We'll have a really great supportive Facebook group as well. And I think the best part, you'll get continuing education credits from it. I'm just super excited to share this with the community. And thank you, Nina, for being a part of it.
Of course, you've got some good names on there too. So we'll make sure we link to all of that and help connect you with that content. And stay learning and stay, up to date with all of that.
Yep. If you want to direct your listeners, you can find it at examroomnutrition.com/course. And Nina will have a special code for you for your podcast listeners as well. You get a special discount just for listening to Nina's podcast.
I love that. Well, thank you so much, Colleen, and we'll, I'm sure, stay in close touch.
Thanks,
All
Nina.
right. Bye-bye.
Bye.